Welcome to the American Heart Association Statements and Guidelines podcast, where we'll discuss clinical practice guidelines and scientific statements on various cardiovascular disease and stroke topics.
Hello, everyone. I'm Salim Virani, and I'm a Vice Provost for Research, as well as a Professor of Cardiology at the Aga Khan University. I work as a preventive cardiologist, and I was honored to serve as chair for the 2023 American Heart Association American College of Cardiology Guideline on the management of chronic coronary disease.
And I'm Kristen Newby. I'm a professor of medicine in the Division of Cardiology and a faculty member at the Duke Clinical Research Institute at Duke University School of Medicine. And I served as the co-chair for the chronic coronary disease guidelines.
So this is our second podcast episode discussing the major takeaways from the 2023 American Heart Association American College of Cardiology Guideline for the management of patients with chronic coronary disease. In the first episode, we talked about what patient-centered care and team-based care mean, in addition to a general overview of this guideline, as well as what does a Class 1, Class 2, Class 3 recommendation means. In this episode, which is the second episode, we will talk about lifestyle recommendations and how do we assess risk when it comes to patients with chronic coronary disease. With that, I'll turn it over to Kristen to talk about what are some general principles when it comes to risk assessment of patients with CCD.
Yeah, so we'll start here with risk assessment, and that's really the foundation upon which we build to make our decisions about treatment. If we don't understand risk, we can't understand treatment benefit and appropriately select therapy. So this is a really important part of what we do. The guidelines has a really well-developed section with a lot of details about evaluation and risk assessment. And we're going to cover the highlights of that. We won't go into detail on everything. But just, for example, for patients with chronic coronary disease, if there's an opportunity to do so, clinicians should first intensify guideline-directed medical therapy and defer testing for risk assessment. So that's one of the key principles. And why do we say defer testing? Well, testing is expensive. Testing has its own built-in risks. There's the possibility that we get false positive testing that we then have to deal with. So there are a lot of reasons to not only assess risk, but also, if appropriate, to defer any testing while intensifying guideline-directed medical therapy.
So, when we talk about a risk stratification in these patients, I think the important thing is to recognize that when we talk about risk, what I would say there are four major buckets of information that we as clinicians need that will allow us to identify which of our patients is very high risk, which patient is not that high risk. And these include socio-demographic variables that we all are aware of, whether that's sex, whether that's social support. Second is patients passed on concurrent medical as well as history related to mental health conditions, because we know that both medical conditions as well as mental health affects prognosis in patients with chronic coronary disease. We briefly talked about ancillary cardiac testing or imaging. That, of course, gives us some ideas about what are high-risk features, which patients are going to have a high risk of cardiovascular events. And then last but not the least, if biomarkers are measured on some of these patients, for example, high-sensitivity troponins as well as BNP in the outpatient setting, these biomarkers can also be helpful when we're doing risk stratification in these patients. And I would refer our listeners to Table 5 of the guideline, which really gets into the details of this. The other aspects of this risk stratification is that when we are evaluating these patients in the outpatient setting, we should get a pretty good sense whether we are dealing with a low-risk patient, an intermediate risk patient, or high-risk patient. And this risk stratification is extremely important. It's actually a Class 1 recommendation because we have a lot of options in terms of therapies that we can use in these patients with CCD. So knowing which of our patients with chronic coronary disease are low risk, intermediate risk, or high risk will allow us to intensify those therapies and maximize the benefit of those therapies. So that's one. The second aspect of this is, which is extremely important that we have learned from a lot of randomized control trials, is that optimization of guideline directed medical therapy is extremely important in these patients to reduce cardiovascular events. In fact, most of the revascularization procedures that we perform are only needed for symptom relief, except in some very important patient groups that we will talk about. So it is extremely important that we look at guideline directed medical therapy as an important cornerstone in patients with chronic coronary disease. And of course, throughout this podcast and the next podcast, we'll talk about what guideline directed medical therapy means. And then the third aspect of this is that there are some patients with chronic coronary disease or suspected chronic coronary disease where it might be important to perform a coronary angiography to assess coronary anatomy for risk stratification purposes. These include patients with newly reduced LV systolic function, those who have clinical heart failure, or both. In these patients, it is advisable to perform a coronary angiography to assess coronary anatomy and guide potential revascularization. At the same time, what our listeners will notice that there is a class 3 recommendation that there is no benefit of using coronary angiography for risk stratification routinely without any history of LV systolic dysfunction, heart failure, or patients who have stable chest pain who really are symptom free on guideline directed medical therapy. So in these patients or patients where there is not a high risk based on non-invasive testing of left main disease, in these patients invasive coronary angiography is not recommended for further risk stratification. So those are very important consideration when we are looking at risk stratification in these patients based on socio-demographic variables, based on imaging, as well as in some cases, the use of invasive coronary angiography. So now once we have performed a risk stratification, of course, it is now time to start talking about therapies. And the first and the foremost out of that is lifestyle recommendations. And in that, nutrition is extremely important. So I'll pass it over to you, Kristen, to tell us a little bit more about what nutrition recommendations that we have in the guideline.
So nutrition is one of those foundational components of managing chronic coronary disease. So important to augment pharmacologic therapies with non-pharmacologic approaches, which means a healthy diet, exercise. This, I think is probably underemphasized in a world where we have so many interventions and medications that we can use to treat patients with chronic coronary disease. So we felt it was really important to include this and emphasize it in this guidelines. So we want to encourage patients to eat a heart-healthy diet, and that means a diet that includes fruits and vegetables, legumes, nuts, whole grains, lean protein, complex carbohydrates, and dietary fiber. We want them to avoid bad fats or replace bad fats with good fats, reduce the percentage of calories overall that come from saturated fat, and use monounsaturated and polyunsaturated fats like olive oil as an example. We also want to encourage minimizing dietary sodium to at least less than 2,300 milligrams per day and optimally closer to 1,500 milligrams per day. We recommend minimizing processed foods like cured bacon, hot dogs that transmit a lot of these unhealthy fats to the individual. And then for carbohydrates, we want to, again, look for complex carbohydrates, avoid the refined carbohydrates that we find in processed foods like ready-to-eat breakfast cereals, white bread, white rice. So think about natural grain, long grain rices. And then really importantly, the emphasis on avoiding sugar sweetened beverages like soft drinks, energy drinks, fruit drinks that have added sugars. We also have some emphasis on trans fats, and trans fats are the hydrogenated vegetable oils. They're the things that have been added to help stabilize many of our baked goods and other processed foods to increase shelf life. They're also found in restaurant food that involves deep frying. So, understanding the sources of these, I think we can really help our patients avoid these bad things. But we have to have these conversations and we have to make it part of our culture in treating chronic coronary disease patients, that this is something we review at every clinic visit. We also have a recommendation regarding nutritional supplements, specifically that we do not recommend nutritional supplements because there's no evidence that they provide benefit for preventing heart disease and stroke events.
So, in addition to nutrition, another really important lifestyle component when we are trying to prevent or treating chronic coronary disease is physical activity. And as a lot of you will notice, the guidelines have actually stopped using the term exercise. It's cumulative physical activity. So as long as our patients with chronic coronary disease are free from contraindications, and those would include unstable angina, decompensated heart failure, uncontrolled arrhythmias, or acute thromboembolic disease, a good physical activity regimen is recommended for all patients with chronic coronary disease. So, when we talk about physical activity, there are four recommendations that are extremely important for us to follow as clinicians and recommend very actively to our patients. First is that we recommend more than or equal to 150 minutes of moderate intensity aerobic activity, or more than or equal to 75 minutes per week of higher intensity aerobic activities for every patient. Now, this is the same across all the guidelines that we have in terms of physical activity or exercise. So that's number one. Second, it is extremely important for patients with chronic coronary disease to actually supplement this aerobic activity with exercise that improves strength and functional capacity. And then those exercises have also shown to improve risk factor control. So, a combination of aerobic activity and muscle strengthening exercises is extremely important. We also have a class 2 recommendation for patients to reduce sedentary behavior. Now we know that 150 minutes is really where you get good amount of benefit. In fact, there is just a steep curve up to 300 minutes. But what we know is that for a person who is very sedentary, they can gain benefit even up to 150 minutes, even if they increase their physical activity by 10 minutes, 20 minutes, 30 minutes. So we have a class 2 recommendations for patients who are very sedentary to increase their non-sedentary time or reduce what we would call a sedentary behavior. Now, last but not the least, a class 1 recommendation that is extremely important, and we know that this is a problem in taking care of patients with chronic coronary disease, is recommendation related to cardiac rehab. We know that in patients who've had a recent MI, PCI, or who've undergone coronary artery bypass grafting, patients who have stable angina, patients who have had heart transplant, or patients who recently had spontaneous coronary artery dissection related event. In all of these patients, we have class 1 recommendation for cardiac rehab. And this is extremely important because we know that referral as well as continuation of cardiac rehab is extremely low in these patients. And we know that it improves control of risk factors, it reduces symptom burden, it improves quality of life, and for some of these conditions, it reduces mortality as well. So we would highly recommend that we all as clinicians pay attention and identify our patients who are good candidates for cardiac rehab and then refer them for cardiac rehab.
So let's talk a little bit about tobacco and substance use. I think we all know that smoking and use of tobacco is a major cause of cardiovascular disease, and certainly important that we eliminate that in our patients who already have chronic coronary disease. So we have several updates to the guidelines regarding tobacco use and screening for tobacco use. So if we don't ask patients at every visit whether they're smoking or not, we can't help them stop smoking. So It's a class 1 recommendation now to assess tobacco use at every healthcare visit. That's not just at the cardiologist's office, that's every healthcare visit across the healthcare spectrum. Again, to help us identify patients who could benefit from interventions to help them stop smoking. We also have a class 1 recommendation to use behavioral interventions, so counseling, coaching, peer coaching to help maximize cessation rates, in addition to pharmacotherapy that may include things like bupropion or varenicline in combination with long and short-acting nicotine replacement therapy. Another updated addition to this guideline that we talked a bit about is to avoid secondhand smoke exposure. So, secondhand smoke almost equally toxic from a cardiovascular perspective as primary cigarette smoking. So, things that one might consider as counseling family members. So, this is where the environment and the social determinants come in. We know that there are rules and regulations now in many places about public smoking to help reduce the secondhand exposure, but there's still a fair bit that occurs at the home, and we have to be aware and assessing this to help our patients. We also have added an update with regard to e-cigarettes. And we know that e-cigarettes increase the likelihood of successful smoking cessation compared with nicotine replacement therapy. But we don't really have long-term safety data and understand the risks of sustained e-cigarette use. So we do not recommend e-cigarettes as first-line therapy for smoking cessation.
Now, building on to the same topic, we also have recommendations related to alcohol as well as substance use. Now, we have a class 2 recommendation to advise women with CCD to have 1 drink or less per day, and for men with CCD to have 2 drinks or less per day. And then we also have a recommendation not to recommend alcohol use for patients with CCD just for cardiovascular disease prevention, because we have a lot of data now that may not be the case. So the message is not to recommend alcohol for cardiovascular disease risk reduction in patients with CCD, but at the same time, those patients who are using alcohol to limit the use of alcohol. The other aspect of this is that we know that certain substances are not good for cardiovascular health, and they become even more important in patients with CCD. And these include the use of cocaine, marijuana, and opioids. So again, these are substances that we should routinely ask about when we are evaluating our patients, and then counsel against the use of these substances because they could be harmful in patients with chronic coronary disease. Now, we're talking about lifestyle in general. So, the other aspect of this where lifestyle becomes extremely important is when we are trying to talk about control of blood pressure. And that, again, is an area where non-pharmacologic interventions become extremely important. So, for example, weight loss, healthy diet, reducing the intake of dietary sodium, increasing the intake of dietary potassium, increasing physical activity, as well as moderation of alcohol intake are extremely important when we are trying to look for non-pharmacologic ways of lowering blood pressure. And our clinicians will find a very useful table 12 in the guideline document that actually talks about these non-pharmacological means of reducing blood pressure, which is adapted from the hypertension guideline by the American Heart Association, American College of Cardiology. So once that's done, then of course we can use medications for hypertension once lifestyle is instituted. And then that probably is very clear to clinicians when to use beta blockers when somebody has had recent ACS, has LV dysfunction or continued angina. When somebody has LV dysfunction, concomitant diabetes with CKD, then those are the patients with ACE inhibitors and ARBs can be used. Similarly, patients with LV dysfunction, one would use aldosterone antagonists. So those could be individualized based on patients' clinical condition as well as whether or not they have LV dysfunction or continued symptoms of angina. But first and foremost, it is extremely important to try out lifestyle therapies when it comes to even management of blood pressure in these patients.
So, sexual health is a large component of quality of life in our patients with chronic coronary disease. So, we've added some recommendations about counseling patients around sexual activity. So, first, to kind of equate sexual activity to other activities, sexual activity is about 3 to 5 metabolic equivalents. We have a class 2 recommendation that resumption of sexual activity should be individualized based on type of sexual activity, their overall exercise capacity, and the exercise capacity related to that sexual activity, and any post-procedural healing issues. Cardiac rehabilitation and regular exercise reduces the risk of cardiovascular complications with sexual activity. So we want to encourage regular exercise and engagement in cardiac rehabilitation as a part of expanding that aspect of quality of life for CCD patients. So one important thing that we want to highlight is that the phosphodiesterase type 5 inhibitors, or PDE5 inhibitors, should not be used concomitantly with nitrate medications. And the reason for this is because of the risk for severe hypotension when these medications are used concurrently.
So that's it for the second of the 3 episodes that we have for the chronic coronary disease guideline from the American Heart Association and American College of Cardiology. In our last and third episode, we'll get into some of the major updates in the guideline regarding statin therapy, antiplatelet therapy, weight loss, revascularization, as well as recommendations related to special populations. We hope to see you again. Thank you for listening.
The data and statistics presented in this podcast are from the official guideline being released by the American Heart Association. Any and all personal stories and testimonies are that of the talent, host, and volunteers, and are not reflective of any statements or position of the American Heart Association. For a full manuscript of the guideline released, please visit the official American Heart Association website at professional.heart.org.